Yeah, I think that's good. All right, awesome. So like I said, my name is James Abuaji. I am one of the Community Advisory Board members on the CHIPTS CAB. And the person who will be co-moderating or moderating is Natalie. She's a co-chair and moderator for the CHIPTS CAB and this event. So to talk about the reason why we're here today. So every year, the CHIPTS CAB chooses an initiative that is in conjunction with the times or something that they feel really passionate about. And this year, in conjunction with a lot of the civil and social unrest that were happening the time of COVID and also the beginning of COVID with the different murders of George Floyd and Ahmaud Arbery, amongst many others. We thought it was very important and imperative to talk about the role of systemic racism within our world, but specifically the impact of systemic racism on PrEP uptake in the Black and Latinx communities. And so that's what we'll be presenting to you today, kind of like an overlook of how systemic racism plays a role within PrEP. And thinking about our kind of agenda for today, you'll be looking at speakers who will be addressing different points that talk about systemic racism in kind of different lenses. You have the opportunity to go to breakout rooms to share steps and ways to address systemic racism, and a discussion go along with it. And then you'll also have the opportunity to kind of view a panel discussion from consumers and providers that are going to be sharing their experiences dealing with the topic of systemic racism and PrEP uptake. And hopefully by the end of the day, like the title says, we'll have a solutions-oriented approach for the future and moving forward in that type of lens. So now I'll pass it over to Natalie.
Thanks, James. Welcome everybody to today's conference on systemic racism. I get to go over the housekeeping. So some housekeeping for you all. Please, if you have any questions throughout this conference, please post it in the chat and we'll have opportunities to either address it following the panel discussions or via email if we don't have enough time. Fortunately, you're all at home or in your offices, so you know where the restroom is and you can use the restroom at your own pleasure and own time. We will have a break. We have a scheduled break 11:45 to 11:55. We do ask that you stick around for both the panels, but also the breakout groups. Today is really about developing solutions. So not only identifying the problem and having a conversation about the problem, but coming together as a community in Los Angeles County so that we can have conversations about how do we rectify some of these challenges that we're experiencing. This is a look at the agenda. So we will go all the way to 1 o'clock. We have a packed agenda. We have a wonderful group of speakers. I think as part of our CAB, you have a group of very passionate individuals who are very committed. And as James was saying, our project this year was addressing systemic racism and PrEP. And I just want to do a shout out to Thea Eski, who is the filmmaker who filmed and edited today's PSA. Also shout out to Lucky Alexander for providing the filming equipment, and also to Dr. Tri Trang for his contribution in shaping the questions, and to the CHIPTS CAB members for today's video. So I have the pleasure of now, we all get to watch today's PrEP PSA.
Basically, when it first came out,
through some of the workshops that I had been to.
In my actual intro to LGBT studies course.
My psychologist actually helped me find PrEP.
Non-biomedical approach to HIV prevention wasn't working. You know, we're still seeing roughly, 40,000 new infections every year. That had sort of been plateauing. And so we weren't making any more dents in terms of HIV prevention. So to have another tool in our arsenal that was highly effective, it was groundbreaking. It is groundbreaking.
I truthfully think that anybody who is sexually active, who has folks who have sex with multiple partners, folks who aren't using condoms, whether they're using it only a majority of, some of the time, like all of those folks I think are eligible for PrEP. So I think trans men absolutely are left out of this equation.
I was told that I wasn't a good candidate for PrEP. Trans men are often left out of the testing, are often left out of even providers asking, you know, like what are those sexual behaviors that folks engage in order to assess risk. When you don't see yourself reflected in the messaging, when you don't see yourself reflected in the data, then that sends a strong message that this particular product may not be for us.
The marketing needs to change to reflect these communities and to also invite them and to show that, like, yes, this is a viable option for you, and there needs to be representatives from these communities being vocal about their experiences. Yeah, definitely. I think that the longer I've been on PrEP, the more and more confident I am, just in terms of like knowing that it's there to protect me. I think there was some initial uncertainty because I think like in the early years, obviously we know that if you're taking PrEP every single day, that it's a highly efficacious prevention strategy. But I guess in my own way of like testing whether or not it really worked, I was starting to have like sexual relationships with men who are HIV positive. And so even after a sexual encounter, there still was some uncertainty of like, oh gosh, I really hope this protects me.
Being in a community like South Central Watts, where I'm at, where it's HIV is highly prevalent, right? So the greatest need is here, and probably the greatest amount of skepticism is here. Well, I mean, it dates to the beginning, right? I mean, what I mean by that is the birth of U.S. capitalism was born and integrated with slavery and anti-Black racism as like part and parcel. You can't really separate the two. And the way Black people in this country have been treated from the beginning till then. I mean, throughout slavery, there's all kinds of medical experimentation. You know, it was all about, you know, to the degree that there was any medical assistance, it was about maintenance of slavery, right? Maintaining the minimum amount of help to maintain slavery. And then there was all sorts of experimentation on top of that, right? I mean, there's a number of obstetric, measures that we actually today still in medicine date back to experimentation during slavery. After slavery, there was within the jail systems. I mean, people always reference Tuskegee, but there were many other forms of medical experimentation in the Black community. So it's not even. I mean, it's literally is a continuation of where medical science is really under a kind of dictatorship of a racist system. And so to then say, now we have this here available that's born out of this medical system, and say this is a benefit. Well, there's clearly, and there should be, skepticism. It's real, you know. And that's I don't try to, when folks bring up all these various, you know, some of it's maybe outright conspiracy theories and have no validity at all, but it is, to the degree that it is valid, it's based on the realities of medical experimentation, of racism within the healthcare system, right? So I think it's just acknowledging that reality and saying, here though, within the limits of this current period, right, where we're not at least able to address mass incarceration in a more profound way, or employment rates in a more profound way, but we can say here in Watts, here in South Central, here in the south of the U.S., wherever, right, where HIV is prevalent, this medication can prevent you, who's sitting right here in this exam room, this could prevent you from getting HIV, right? It may not be the stopgap for the epidemic as a whole, but from an individual standpoint, we can make a difference.
I know you can't hear anyone else clapping, but this is really, I guess, setting the stage for today's conversation. I really hope that this video is kind of a time capsule. As we look back in 2 to 3 years, we can hopefully say, remember when we started the conversation about getting more Latinx and Black and communities of color on PrEP, the challenges we had, and hopefully we're in a better place in 2 to 3 years where we can say that's no longer an issue. But for now it is, and so we have to have a conversation, and I'm going to introduce you. We're going to go into the panel discussion. Each presenter is going to have 5 minutes to present. As a reminder, if you need continuing education training, CE credits, please register with Pacific AIDS Education Training Center. It is in the chat. So now I'd like to introduce you to our panelists, starting with Felipe Finley, who is a physician assistant, and really he brings the perspective of social justice, and he constantly reminds us of the fact that our little HIV microcosm is a larger reflection of the larger community. It's always great having conversations with Felipe as he reminds us of looking at the incarceration history and how that impacts communities of color. Next, we have Dr. Naina Harara, a professor in residence and an accomplished researcher who is really leading conversations around systemic racism and HIV, who will be presenting us with data. Next, we have Miguel Bujanda, Executive Director of Reach LA, who is doing innovative programming in Los Angeles County, reaching both Latinx, communities of color, gay and transgender individuals. And he'll be presenting the non-traditional method of enrolling individuals into PrEP. Then we have Lorenzo Banda, a dedicated HIV worker who I've known for a very long time. And he'll talk about his real world experience as a PrEP navigator at Watts Healthcare. And last but not least, who tends to be always a highlight and somebody who warms up and is a light in any webinar, Zoom, in-person meeting, we have Terry Smith, Director of Sexual Health and HIV Prevention Services at APLA, and who will be talking to us about sexual health and PrEP in APLA. So let's start with Felipe and your presentation.
Hi, good morning, everybody. My name is Felipe Finley. Thank you, Natalie and James and CAB team, CHIPTS team. I stated I'm a PA, physician assistant here in Watts. I'm also a member of the CAB here at CHIPTS, and just really it's kind of a pleasure to be here and to kind of kick off a discussion that, you know, is centuries old, as you all know, and the fact that we're having it now speaks to, you know, the sort of uphill battle that we have. But I'm glad that it's, you know, really getting started. You know, and again, you know, I have a few minutes to talk about a really broad topic. So I'm just going to kind of gloss over things. Feel free to reach out to me afterwards. And also, you know, again, like the idea here is to kind of kick things off. I'm also a member of the HIV Commission, and just started this year, so it's kind of really a privilege and an honor to be a part of this team. But also, we're starting a conversation about systemic racism as well. So I thought I'd share a few excerpts to kind of frame our conversation. It's not letting me advance to my slides. Yeah, why I want to do that? Any ideas on why I can't share my slides? I'm sharing it, but I can't advance. Let's see. Arrow, maybe. Arrow. I got it. The arrow. Sorry about that. So that makes sense. So one of the books we're reading, sorry about that. So one of the books we're reading is So You Want to Talk About Race by E.G. Omoluwo. Okay. And this is how she frames it. Okay. Race as we know it in the US is closely integrated with our economic system. The system of racism functioned primarily as a justification for the barbaric act of chattel slavery and the genocide of indigenous peoples. You cannot put chains around the necks of other human beings or slaughter them wholesale while maintaining social rules that prohibit such treatment, without first designating those people as somewhat less than human. And later, the function of racism was somewhat repurposed as a way of dividing lower classes, still with the ultimate goal of economic and political supremacy of white elites. Race was not only created to justify a racially exploitative economic system, it was invented to lock people of color into the bottom of it. So she actually goes on to define race or racism as this. Racism is any prejudice against someone because of their race when those views are reinforced by systems of power. Okay, so that's how she defined it. Personally, I'd like to tweak it just a bit because we know that racism is more than a certain set of beliefs, but of practices, right? Of practices. So to me, racism is any prejudice or practice against someone because of their race when those views or practices are reinforced by systems of power. Okay, so this is sort of what we're up against, and it's really integrated in every aspect of our society. So looking at it briefly over history, you can glance at this slide. I won't go too much into it, but since the conquest and the mass genocide of indigenous peoples, right, this technically wasn't based on skin color yet. It was based on ethnic and religious differences, but was equally about, profit and land and other means of exploitation. It wasn't until the 1600s where race was created as a social construct, right? Not biological, where the concept of Black and the concept of white and other in terms of racial groups was codified into law, right? Into law, into the sort of lifelong enslavement of people from Africa and the creation of this concept of race. And then even after the abolition of slavery, of course, we know people hopefully have seen the documentary 13th and know about the 13th Amendment, right? The use of slavery to maintain slavery based on if you've been incarcerated or not, and which has sort of continued to this day as one of the main ways in which systemic racism and particularly targeting of Black people, but also all people of color, Latinx, Indigenous, et cetera, as being some of the key ways in which systemic racism manifests. And in terms of medicine, right, it's been under this dictatorship. It's been under this. So these are a few books and examples on ways in which slavery. So for example, Dr. Marion J. Sims, who's considered the father of gynecology, experimented on Black women, Black women's bodies for procedures that would be used later on white women, but without anesthesia. Okay, and these are just one of the many examples in which medical experimentation was used. Folks can sort of reference some of these books. People know that The Immortal Life of Henrietta Lacks. This book was about, the use of her cells and advancement of, or use of her body, her cells, against her knowledge and against really the knowledge of her entire family for decades, used to advance medical science, right? So there's this long history of sort of repression and dictatorship of medicine and how systemic racism has been used. And so this last quote here, systemic racism in medicine, from slave cabins on Southern plantations to clinics, hospitals, and medical college in northern urban centers illustrate how race, gender, and health influence the doctor-patient relationship. Now, of course, in every form of repression, there really is a form of resistance. So, that also took the form of medicine. So there was obviously the abolitionist movement to end slavery. There were numerous rebellions against slavery. And Harriet Tubman, in fact, was a nurse. I don't know if people know that, but she was a nurse. And during this period, there was a reliance on midwifery, on conjuring, on sort of herbalism and other forms of medicine that was from the slave perspective in terms of maintaining health and a sort of reliance on that. So there was this tension between the sort of dominant class and the sort of repressed class and how medicine and which way medicine took shape. And I think we still see that today. In the civil rights movement, we know about, obviously it's for civil rights movement, the Black Power movement, but these were some of the greatest advances in health actually of Black people and all people of color during this period, whether it was sort of the gaining of wealth, the gaining of actual medical access. There was a narrowing in the racial disparities in health during this period. People know about the Black Panther Party, who had free clinics all over the country. They were the first to start national testing for sickle cell before any other institution. So the Black Panthers, led that. And I don't know if most folks know that. And of course, we also know about the movement, the LGBT rights movement that started sort of in the late 60s and early 70s, picture of Marsha P. We know about the Stonewall rebellions, et cetera. All of these movements also influenced and shaped, and some of them were actual activists within the ACT UP movement. And we think about the gains, the medical gains in this resistance in terms of the fight for antiretrovirals to be available and tested and to have early access, all of which has shaped medicine. So this form of resistance against repression has also been instrumental in terms of the medical gains for people of color in particular. So how does systemic racism actually impact HIV rates in sort of disproportionate ways in which we see them? So this is sort of a quote here. Research has shown that even when risk factors are equal or less, sexual minority youth face a higher risk of HIV and STDs. The pool, right, of sexual partners are more likely to be HIV positive, right, or having STDs, but why, right? Again, why is that the case when Black folks or people of color in general have the same or fewer risks and yet face higher rates of HIV and STDs, right? And again, right, racism is the most significant contributor. Racism is intertwined with underemployment, unemployment, decreased access to medical care, and with incarceration, right? So one way to look at systemic racism is this sort of broad, multi-connected forms of systems, starting with one, the historical racism on the left here, you can see, and then the unequal rates of HIV on the right. And you can see here, right, medical mistrust is a part of that. So in addition to mass incarceration and poverty and drugs in our communities, et cetera, right, all of that is influencing the mistrust of the healthcare system, and all of that is influencing, of course, rates of HIV. So here we are at our conference, right, on starting this early conversation on how systemic racism impacts PrEP uptake, right? And really in how it impacts our communities, and PrEP being just sort of one example of that. We have our 4 pillars, and prevention is one, right? So these are four pillars on which we're going to end the HIV epidemic, and prevention is one. And obviously PrEP is sort of the sort of, more sort of instrumental tool that we have available for us at this point. And yet we're seeing these discrepancies in uptake. The HIV Commission, as I mentioned, LA County, both have these strategies for ending HIV. And we're barely starting this conversation on systemic racism and its impact. But as I mentioned, there's also been resistance, right? And James mentioned earlier about, Ahmaud Arbery and George Floyd and Breonna Taylor, et cetera. And the names, Adam Toledo in Chicago, I mean, the names are endless, right? Black, brown, our trans and gay community also disproportionately impacted by police violence. And there have been rebellions, and rebellions have forced this conversation to force us to start really having this conversation, right? And so I think we got to credit the people out in the streets, and we have to think about how to use this movement to shape our practice, right? How are we practicing? How does our healthcare system look? Who are our practitioners, right? And in thinking about how we can sort of kind of blend these two struggles, I think that's where we're going to find. That's where we're going to sort of create the real possibilities of ending systemic racism as it relates to PrEP. I think that has to be incorporated into our 4 pillars there. And that's all I have. Thank you. This is my email. These are some local struggles that are happening here regarding healthcare and systemic racism if folks are interested. Thanks again to the CHIPTS CAB for having me, and look forward to our discussion. Thank you.
Thank you, Felipe. So as a reminder, we're going to take questions at the end. So now we're going to transition to Nina's presentation. So as she's pulling that up, all right, here we go.
Good morning, everyone. And my job is in a short amount of time to talk with you a little bit about where we're at in LA County and California in terms of PrEP uptake and how that varies across racial and ethnic groups. And then I will spend a few moments, bring us back to where Felipe left off, which is what does systemic racism have to do with what we're seeing? I want to acknowledge the centers I'm a part of, as well as my colleagues who have contributed to this work, and as well as Wendy Garland from DHSP and people with the State Department of Healthcare Services who provided data. Just to remind people why we're talking about PrEP, it is a key part of both the California, the LA, and the national efforts to end the HIV epidemic. Most analyses and most planning efforts have realized that PrEP needs to be part of the plan and part of hopefully the success of implementing those plans if we are going to reach our goal of ending the epidemic. It's estimated that in the state of California, there's between 220 and 240,000 people with PrEP indications. And for LA County, there's about 73,000. Now, I'm not going to share a whole lot of data. I only have 5 minutes, but I want to share a few pieces of information just to give us a picture. These first data come from online PrEP monitoring that LA County has been doing since 2016. Twice per year, they do brief survey questions with a sample of Black and Latino men who have sex with men and transgender persons who are recruited through dating apps. So this is not necessarily a representative picture of these populations, but it's a decent large sample to give us some sense of what is the levels of PrEP awareness and use in these groups and how it's changing over time. You will see on this slide that the issue is probably no longer awareness, that since 2016, awareness has gone up and then plateaued, but about 90% of most of these groups, of these groups, maybe somewhat lower for transgender persons, but overall about 90%, maybe a little bit more, maybe a slightly less, are aware of what PrEP is. So education has at least been somewhat successful in making people aware of PrEP as an option. When we get to use, however, it's a much different picture. And so these specific slides, you can see the trends in use. And while there has been an increase, especially between 2016 and 2019, between 2019 and 2020, there was definitely a leveling off and very little change. It's a little bit difficult to know what happened in this slide in terms of 2019. It looks like there was a huge increase in uptake, actual PrEP use among transgender persons, but we only have that one data point. And so it's a little bit hard to say without more information whether or not that's an anomaly, but it may be a very good sign that use is increasing within that group. But now I want to look at where the disparities are and may lie. These data come from the LA Health Survey, and it's specifically among Black, Latino, and white men who have sex with men, transgender persons, and women of color who have indications for PrEP, something related to their sexual behavior or STI history indicates they may benefit from PrEP. We see use rates are highest in white MSM, but not that much lower in Black and Latino MSM. But this is where the disparities really come in. When we look at current use, so those are people who've been prescribed. Here now we're looking at among people with an indication for PrEP, who's using them currently. We start to see pretty significant disparities with 36% of white MSM currently using compared to 29% of Latino and only 22% of Black MSM. Among transgender persons, we see somewhat of a reversal with higher rates of current use among Latinx and Black transgender persons and somewhat lower rates among white individuals. And then other groups, heterosexuals, people who use drugs, who inject very low rates. We've done similar looks, slightly different, but similar looks at Medi-Cal beneficiaries within the state. But we looked at the data somewhat differently in that we calculated PrEP to need ratios, which are actually better at really looking at who is in need of PrEP and whether or not there are disparities across racial and ethnic groups. We don't currently have that data for, we don't currently have that way of looking at the data for LA County. And what you see here is a much starker picture when you actually take into account need, which is measured by the number of people in the prior year who were diagnosed with HIV in each of these groups. You see much larger differences with the rate the PrEP to need ratios. Higher is better, being 3 or more times higher for white and Asian men who have sex, men and women, sorry, just men and women, regardless of sexual orientation, among Medi-Cal beneficiaries. And these data are really important because everyone on Medi-Cal has access to PrEP. So the issue here is not ability to get a prescription. So to summarize, prescriptions are below targets across all racial and ethnic groups. When you look at current use, you really start to see the disparities. And then when you look at use relative to need, you start to see an even clearer picture of the disparities with white and Asian men and women having much higher PrEP to need ratios than is seen for Black and Hispanic females. Unfortunately, we don't have these data for transgender persons at the state level. So just the policy implications. So simply looking at who has a prescription for PrEP tells a very incomplete story. And we can further argue that traditional risk indicators miss many of people who are at risk, which is why the PrEP to need ratios tell a different story compared to uptake among people with indications. We need to attend to these disparities. Otherwise, as we increase PrEP uptake, there's the potential that disparities will grow if we don't attend to equity as opposed to going down. We need to focus on Medicaid agencies as a place where we can increase uptake, but keeping in mind at the national level that Medicaid expansion states often, that the states that have not expanded Medicaid tend to be states where there are disproportionate numbers of Black and Latino people. So one can see, I would argue that systemic racism in many ways is part of all of these stories. And I just want to end talking about this first one, that most of our referrals and our indicators for sending somebody for PrEP based on if they tell us certain things that indicate they're at high risk for PrEP. But we know from reams and reams of data that differences in traditional risk behaviors don't explain the racial and ethnic differences that we see between Black and white people. So part of what I'm beginning to argue and think is that if we start to take into account social determinants of health, as well as their behavioral indicators, we may be doing a better job of actually indicating who might best benefit from PrEP. Thank you.
All right, thank you, Nina. Again, if you have any questions for Nina, enter them in the chat. We'll get to them at the end. Now I'd like to introduce you to Miguel Bujanda. I think both Nina and Felipe has set the picture of how we're failing as a system, as a healthcare system. But what's wonderful is not all systems are failing, and Miguel Bujanda is going to share a system that actually works in prescribing PrEP.
Thank you, Natalie. Thank you for having me today. My name is Miguel Bujanda. I'm the executive director of Reach LA. I had the pleasure to introduce you to something that's been going on here at Reach LA. I know Reach LA has been around for a while. Many of you know Reach LA, but we've historically have been a prevention program, solely working on just doing HIV testing, linkage to care services. But we got into the game of PrEP because of the high impact and need for PrEP services amongst our target populations. As many know, we primarily focus on young Black and Latino MSM and young trans women of color. And we really found that providing PrEP services was essential in continuing to be part of the landscape of what HIV services are today. And one of the things in regards to providing these services was finding innovative ways to actually increase accessibility to PrEP services amongst our population. And because we work with a young population, we realized that technology was going to be one of the best ways for us to link people into PrEP services. So, Reach LA has evolved in the last couple of years, and we are renovated our complete space, and look forward to having you all come to our soft open house. Shameless plug there, I know. But ultimately, some of the barriers for PrEP services here at Reach LA is that we're not clinic. We don't have clinic services. We provide HIV testing, STI screenings through community partnerships with local organizations. And we are limited on services for HIV testing and PrEP referrals. And we realized that a lot of the young people that were coming and get tested were still not on PrEP. And as mentioned in the previous presentations, the education is there. People are understanding what PrEP services are and some of the barriers to get into PrEP were because of medical mistrust. The fact that they're going to clinics and the thought of community-based organizations is kind of dwindling away. Being a young gay person back in the 90s myself, working at community-based organizations, a lot of organizations have changed into a more clinical model. And Reach LA, we continue to be a non-clinical model, and we still had a lot of access to a lot of clients that still needed the service, but more importantly, were not accessing it. We developed the telehealth process that we connected with some providers that provided telehealth PrEP services. So Reach LA would be essentially part of the recruitment process to recruit individuals into PrEP services, but eventually was able to move into providing support into the enrollment process with our providers, and also providing STI results, referral services to people who ended up HIV positive or had STI positive. We connected with, again, virtual programming. So everything was through telehealth, through the comfort of their phones. And eventually we're able to partner with Avita Pharmacy to provide us mail home PrEP to the comfort of their own homes. And we would do follow-up services and making sure that they refer them to any other services that are needed, primarily focusing and tailoring to the services that they needed, which were for young people of color. All the staff were really focused on addressing some of the barriers and challenges. If it came to homelessness, if it came to just stigma and discrimination, and more importantly, just being a sex positive space and understand that the importance of PrEP in the fact that they're young people working with young people. We partnered up with programs like, so we partnered with Avita Health, Mr. Sister Program platform, and we were able to actually do very well during the year 2020. We started our telehealth program in January 2020, right before the pandemic. So coincidentally, we had started the model that we were eventually going to be very successful in, because a lot of people stopped going to the doctors. So a lot of individuals stopped going to the doctors and they're like, I need a PrEP service. So when we started to continue to promote our telehealth partnership with Mr., they allowed them to enroll a variety of people. So we utilized great customer service that we required Mr. to provide a cultural competent and cultural proficient service to the young people that we work with, utilizing a very strong social media campaign that targeted the utilization of like Jacked, Grindr, Scruff to really work with individuals in the comfort of their home, right? Because the pandemic was going on. So we had to adapt anyways. So we started utilizing that momentum and just really ensure that we're promoting to the right individuals. We utilize social networks recruiting. So we actually, our existing clientele that we were working with, we connected with them to tell them, hey, tell your friends about this service. So in a great social sexual networks recruitment strategy, people started referring and telling their friends about the service. And we got a lot of individuals that really signed up for the program. And of course, all our specialists here at Reach LA are PrEP navigators. So they're able to connect people and do ongoing follow-up services, making sure that they're doing their home testing kit every 3 months, that they're sending in for their labs, that they're speaking to their doctor through their virtual telephone calls, to making sure that are they receiving their medication on a monthly basis, making sure their insurance updated on the portal if they change jobs. A lot of people lost their jobs during the pandemic. So how do we switch it? How do we switch it up to get them into Covered California or other type of services to make sure that they were actually part of the healthcare system that was able to actually help pay for their PrEP services. With that said, I'm very happy to say that in the first month of before the pandemic really hit, we had about 98 people enrolled in the service. We got a lot of signups. People were interested in the program, but they really didn't know what the program was, and they thought it was a little too good to be true. And so they didn't necessarily they didn't stay with the program. Eventually, we got all the individuals in pandemic hit. We got a huge increase, about 300% increase in March and March and April, and then eventually it skyrocketed. At the end of the year, we were able to enroll about 606 individuals into PrEP in the LA County and surrounding county areas. And if you want to, you're interested in racial breakdown, 49% of them are Latinos. 31% of Black African American, and so forth. So we really focused and concentrated our services in that area to making sure that they're providing services for our target population, which is a Black and Latino Latinx individuals. It's very successful because we met the clients where they needed to, what they needed. We assessed them and found out that, you know, a lot of the programs were not necessarily something that they can do in person because one, the pandemic was going on, but two, a lot of people don't feel comfortable going into the doctor. The time frame for the 600 people enrolled into PrEP services was about a year. So it took about a year to enroll those individuals. And that was through January through December. And one of the things that we're now doing is we're continuing to expand our telehealth PrEP service, but we need partnerships. We need to work with centers that provide PrEP services because our clients don't always want to use telehealth services. They feel more comfortable seeing individuals. So we still refer to in-person clinics that a lot of you provide service for because we need you. The clients need you. But at the same time, I want to make sure that you as a client, as a clinic, feel comfortable enough to send them to a telehealth service if that's more convenient for them. And since we're new in the game, it's important for you to be aware that this is the services that we provide. And it's important that us here at Reach LA start incorporating more medical services because STI treatments needed and other type of preventive health needs are needed. So that's kind of the feature of what telehealth here at Reach LA is going to look like and some of the successes that we've done. So very excited about that. I don't have enough time for questions right now, but it will be available later on to answer some of the questions, or you can reach out to me directly. Stop by our wonderful site. So thank you very much for your time today.
Thank you, Miguel. And Janet said, wow, as to the performance and the number of people that you've been able to enroll. And that's what we wanted, is this model of care where we can actually reach people, specifically Latinx and Black communities, and roll them into PrEP. So if you have any questions for Miguel, please post in the chat. Next, I'd like to introduce Lorenzo Banda, who is a PrEP navigator at Watts Health Community Clinic. All right, we still.
Hey, there you go.
You are. Thank you.
Let me share my screen. Think that looks good.
We don't see the screen yet. All right, we're still seeing the Zoom and not your screen.
How about that?
There we go. All right. And let's do it in slideshow.
We're good?
We're not seeing it in slideshow, but we can see the slides. So if you, on the upper right, press slideshow.
I thought I did. Okay, upper right.
The
Does it
top.
show?
Well, I can say we can see it. So let's.
The top where it says slideshow, home, insert, draw, design on the top menu.
Uh-huh.
Right,
right there.
Slideshow.
Oh, slideshow. Oh.
And then from beginning. Perfect.
Here we go.
We're good?
Yeah, we're, press from beginning all the way on the left.
I thought I did. Okay.
Oh, press it again.
Okay, I guess it's not. You can continue.
Okay, let me see if it's going to respond to me. All right, so welcome everybody. My name is Lorenzo Banda. Thank you, Natalie. Thank you, Felipe. Thank you, Miguel and Dr. Harawa for your input and congratulations, Miguel, on that such a high success rate. So we're going to be talking about the impact of this systemic racism on PrEP uptake in Black and Latinx communities, current best practices. And so as the world deals with COVID-19 aftermath, we get to take a look at how we bring everybody in and how we work now with a telehealth a model and an in-person um, operation. So we're talking about systemic racism in our communities, in our places of business, of work. So looking at within to identify these systemically discriminatory practices or solutions is important, and we're going to talk about how to maybe bring all that together, how to focus that and present it to the higher ups and instill some change. Um, all again for our community members, our Latinx and Black patients, starting PrEP. I'm going to speak about differentiated care as it stands in the HIV continuum and also apply it to PrEP. I believe that really is a model for success. Let me see. How systemic racism really ties into privilege, and income, our employment, and how all of that relates to our health care and how we view it, how, within reaches that for us in a reality. When you grow up in priority communities, as we're labeling Black and Latinx, low income communities now. So systemic racism on PrEP uptake in these priority communities, again, one of the first things that we do is build that trust. And things to remember when building the trust is that we're often the first level of intervention for our patients. And so they may come from all walks of life, not knowing what they're getting into. And just in terms of labeling where they come from, we either label something low income community, well-resourced community, high efficient, and that lets them know. It kind of sets the stage, sometimes sets the tone often. From a very young age, if you are coming from a well-to-do family, both parents are working, it's just, typical, there's trust with the medical staff, with your doctor. You're going from an early age, you've got to know them. There's probably the same doctor throughout your history, your childhood. Not so much if you're a person of color and you're growing up in South Central or other areas like that. So that has to be worked on. That has to be acknowledged that there is none there and there's no history of that trust. Plus, you look at today and you look at what people are remembering from the history of our own country to the treatment of people of color in the Medicare facilities. So, there's not a lot going there for saying, hey, you can trust me. Even myself being a person of color, saying that to someone, that won't necessarily go a long way. So that's really important because it's a person of color seeing their self-worth in that, seeing that may be something that's not for them. So letting them know that is not necessarily understood, but having that conversation with them of what their medical history looks like. Conversations that we're not having today, conversations with women, conversations with men. We've had conversations with the transgender community. We've really kind of gone in there, asked the questions that we've needed to. At Watts Healthcare, we've noticed now that women really are taking on PrEP and are interested. They're seeing themselves as that receptive partner that is at risk. And so what can we do for them? But they still kind of are met with a lot of outside influences that won't allow them to take this on. And so many times, healthcare, money, seeking out a doctor, getting treatment, that means money. That means a lot of money. If it's just a doctor's visit, and I'm talking about the reality for many of our patients here at Watts Healthcare and what we've seen, is that copay from $30 to maybe $60. So as you're growing up and you have this history and your relationship with the medical field is what it is, you have to work. If you want insurance, if you want healthcare, and good healthcare, right? The kind that other people really talk about, you have to work. And unfortunately in our communities, If it's not something local and fast and easy, maybe Target or something like that is also given opportunity, let alone to the LGBTQ community. You have to work, and that brings a lot of pressures with it, let alone getting sick. And then so all of this is just compacting what a person is maybe ready to start PrEP, but these factors are stopping them because there's other concerns. If you get sick, then that means you need that health care, but you don't have a path to it. So that's really left far from your reach, and really only considered to be for very important people, which may not be you. So that is internalized, that is reflected within oneself. And all of this plays a part when you step through that door. So there's so much going on as you step through that door, right? And we talk about this often, but it really does put a lot of weight and stress on a person seeking out even PrEP. Resources versus accessibility. So often we talk about, telehealth. Do they have a computer at home? Are they computer literate? Is there an efficiency to troubleshooting? Do they even have Wi-Fi? If the person doesn't, can they get to a coffee house, a public place? Do they know kind of how to set that up? So troubleshooting these things, mothers today can having to send their kids to school via Zoom, know the troubles of this. And so there's a lot of frustration if you're not equipped, if you're not efficient, or even know the language to how to ask for help. A stopper in continuing. In person, you think it's easier. You think this person, can come in and we've made it easy for you. We'll hold your hand through this process. You have a tour guide. Transportation is key here. Oftentimes time, do they have availability as far as mornings or night? There are very few night clinics, evening clinics in South Central in Los Angeles that I know of. I can name a few. Oasis has like a few days where they offer night clinics, and this is in our community, so where do we go? And we'll get to referrals in a second and where we're sending our patients, because they have to be appropriate. We have to want their success in this. And so all of this plays a part in their stability. That is really to say that things change for people. I may not be here next week. A doctor may change location. So things change not only for ourselves, but for our patients. So don't take things personal. This is a long kind of working modality in that you roll with the punches, you go along with those waves of life that come in, but you continue to seek them out. You continue to offer that support based on what the patient needs. Best practice, we're going to get into some things that work. One of the best ways to deal with telehealth and PrEP uptake in Black and Latin communities is not to deal with a pandemic. So yeah, never have to deal with a pandemic, because that just threw everything out the window, and people really had to take up new ways to engage the community. So kind of what we start with is differentiated care. For me, that really means that you're taking a look at the person that's walking through the door and you're getting to know them. You don't know anything before they walk in through the door. So you're asking questions, sexual health questions, understanding that it is someone that is familiar to the person who they're going to open up to more. So as much as you can, taking a look at, who's coming through that door and what I can ask to get to more information to better tailor a treatment plan for them, right? For their success. That's what we want. So this kind of plays a role into a lot of these factors: continuum of care, the referral. So this is where we talk about appropriate referrals for someone. Am I going to send someone to West Hollywood when they're in Watts? No, I can't. I won't. It won't work for them, So I have to make sure that I understand how they're getting there, how they're getting back, who's going to meet them there, and how will they be treated when they now change their entire environment, and how comfortable will they be when they walk through those doors of some place that, presentation is key, maybe. Presentation is key to us as well, but it's very different in the sense of it starts with the care that you're receiving, and funding permits, we make it better, we scale up. But those referrals are important because, again, in building those partnerships with neighboring community-based organizations and health clinics, there are a lot of places that kind of maybe test but don't offer other services. So really getting to know your community for what it is important. Cognitive dissonance in patients. This is important because I like to talk about kind of the frustration that one deals with in the longevity a continuum of care that we have with our patients, in that, you know, there may be a feeling of, do you even care? You know, we've gone through this before. So that's not your own feeling. That is really kind of the patient there taking a look at what they want and having a conflict with their thoughts, their beliefs, and their opinions. You know, I want PrEP. I know I put myself at risk, and I know I need to make these 3-month appointments, but I don't. And so therefore, whatever I receive, whatever I infect myself with, I deserve it. Or there's that conversation happening internally for them. So it's really, you know, asking them what they're going through, what they feel, and appropriately referring them to mental health or counseling to expand on those conversations, so that they let us know what they're going through. You know, this kind of relates back to, I only deserve the health care that I get because such and such, I grew up here, or I see myself from this community. So it's showing them that it is encompassing, and it is thorough, and it is tailored and thought with you in mind. So, you know, really addressing some of these hurdles, like I said, focus groups are great to present to your higher ups kind of ways that we can resolve some of these systemic racisms that we see in our own institutions. Have community members be a part of that focus group, collect the data that you want to collect, and really present it to appropriate staff, so that the changes that your improvements that you're recommended could really be taken to heart. So thank you all for kind of, you know, sitting with me through this. I hope I didn't take up too much time, and take it back, give it back to Natalie.
All right, thank you, Lorenzo. And last but not least, we have Terry Smith. And again, if you have any questions, please type it in the chat, and we'll have about 5 to 10 minutes for Q&A at the end.
Good morning. Can you see my slides?
No, we can see your Zoom invite.
Oh, well, you don't want to see that. Let's see.
We all have the call-in number.
No, I have a staff person running in here to help this old man figure out how to do this, right? I have it all set up. Share screen. That. Share.
There we go. We see it. Now let's just do it in slideshow.
Okay.
All set.
I'm sorry about that. So good afternoon, everyone. My name is Terry Smith. I'm Director of Sexual Health and HIV Prevention Services at APLA Health. My approaches to this is going to be a little different. I was asked to really talk about more broadly sexual health services kind of post-COVID. And I think it's important that we look at this, particularly as we talk about systemic racism. It's also important that we talk about and acknowledge the last year has been really hard on this work. We know that prior to the pandemic, PrEP uptake was not where we wanted it to be, particularly in the most vulnerable communities. And we also know that we were in the midst of an STD epidemic. And so there were a lot of challenges. And so as we talk about looking at that system, we also understand that in the year 2020, that many services were severely restricted. Many of us who provide these services were only testing people who were symptomatic, treating folks who were symptomatic. There was limited routine testing for HIV and STD. There was longer wait times for new PrEP patients to access services. Existing PrEP patients were able to get refills and things like that, but if you were a new person wanting to get on PrEP, it was challenging. And then there was also individuals who were reluctant to come into a clinic, primarily because of just the quarantine, the shutdown order, just fear of going into a clinic that's already dealing with COVID. And so all of that has kind of created an environment that we had to really think about. And fortunately, during this time, there was lots of conversations about COVID and the impact it was having on the work that we do. Again, we know that people did not stop having sex. We know that for many of us who do this work, we are just getting people into the practice of routinely testing for HIV and for STDs and talking to people about getting on PrEP and all that, and the pandemic hit. And so it was important that the community was having these conversations about what this impact was and what's going to be what it's going to be like after things are all over. And so the response, I think, from the provider community was amazing. I think Miguel, the story that he shared with what Reach LA is doing was just a really great innovation. So for HIV and STD, many of us implemented at-home testing programs. We focus on treating symptomatic STD folks. We prioritized PrEP services because, again, people were still having sex, right? And so the ability for those folks who had put themselves at risk and wanted to come in for PrEP to get into the system was important. And then for those folks who had fallen out of care and wanted to get back into care, it was important to get them in there as well. And then again, the use of telehealth services for PrEP. And certainly at APLA and many others had done that in terms of signing people up for PrEP app and completing Gilead patient assistance forms and all that other stuff was all really important to keep us going. And so as we kind of enter this post-COVID world, one of the things that I think about is we saw how we all kind of came together, we as a community came together to really roll out the vaccine, right? There was kind of all hands on deck. And although there were stumbles and trips and all that, at the end of the day, it became fairly simple. Now imagine if we use that same energy to address STDs in our community and to get people on PrEP and all that. And so I think we now have an opportunity to recast how we deliver these services. I think we need to look at how we create multiple avenues for individuals to access sexual health. So folks who want to go into a clinic should be able to go into a clinic. Maybe in terms of getting their lab work done, they don't necessarily go into the clinic, but maybe they go to the contracted lab that agency uses. Expand the use of at-home test kits. Here at APLA, we have been doing HIV home test kits for a while now. We want to expand to doing STD because we think it's important. We know that some people have gotten used to that, and we want to provide them that opportunity. And again, expanding the use of telehealth to really get PrEP out there to people. I think also focusing on easier access and efficiency, as Lorenzo talked about, the importance of having evening hours, weekend hours, making it more conducive to the individual so that they can get these services that kind of work for them. And then also using technology, so the ability to make appointments and complete paperwork online. I am a big fan of getting rid of these invasive risk assessments. Oftentimes people come in for these services, they got to kind of give this whole why they did it, who they did it with, how long they did it with, and all that, which I don't think is really helpful because at the end of the day, we're dealing with that individual. And we want to create a system where that individual can come and access services freely and as quickly as possible. And then finally, I think we need to look at how we offer these services and take into account the whole person. So we're talking about systemic racism, right? So thinking about trauma-informed care. So when that person is sitting in front of you, it's just not about giving him PrEP or doing this or doing that, but really meeting that person where they're at. Because for many people, the reason they might not get on PrEP is because they're homeless. So let's address the homeless issue, or let's address substance abuse, or whatever that issue might be, as well as in helping the person access services. Thank you.
Thank you, Terry. All right, so now we're in the Q&A. Luckily, we still have Miguel on the line. So if it's okay, Miguel has to leave soon. So let's take any questions for Miguel. I did see something in the chat asking what were the age range for those that were enrolled in PrEP?
Yeah, so the age range is 18. We had between 18 and mid 40s to early 50s is the median for the older populations, but we had some people in their late 50s that they don't sign up with the program, and we allowed it because again they utilize their insurance and the programs, so they could do it as long as it's accessible. Increasing access is our main priority.
All right, thank you, Miguel. The next question is from Nina. Can you speak about PrEP persistence in the program?
All these questions are coming out. So
yeah, I said he only has a few minutes.
I have a few minutes, y'all. But I promise I will. If you want to set up chats, I'll be more happy to chat with y'all individually if you have to talk. But so let's see if I can answer some of these questions. PrEP persistence in my program. What is that? Is that a term?
Is that I believe it's retention?
Retention. I think they're referring to retention.
Yeah, okay, retention, yes. So yes, a lot of the people, because we call them every 3 months and we have a conversation with them every 3 months, like, hey, your kid's coming in, to do your home testing kit. And then we reminded, like, you need to have your phone call. They had to do their virtual calls and their lab work every 3 months. So we had about first couple of months we were doing this, we had about like 80% were staying in the program for the 3 months, and then eventually some would fall off, but then we'll just get more signups. Currently today, we have over 768 people right now signed up on PrEP service getting prescribed on a regular basis. In regards to my strategy for recruiting recruiters, young people know young people. So the thing is, they recruit their friends. That we empower them and we train them utilizing the social network recruiting strategy that CDC approved. And we utilize that strategy to really do that. So I have a background in capacity building, working when I was working back in the EPLA, and we utilize social network recruiting to almost like a pyramid. Like, you get people to recruit people that recruit people, and this community, the community here at Reach LA, the young people, they know each other very well. And they know each other for many years. So we've been around for 30 years. So we have a lot of young people that grew up through Reach LA. So a lot of these people come back to really help out the young people. So we definitely wanted to make sure that we utilize those networks.
There's a question about, and I think it's an important one, about asking about resistance from medical providers to prescribe PrEP. And how did you address that? So I know that's not something, but maybe you can respond to the question.
Yeah, so to respond to the question is, our providers were specifically PrEP providers. So when they applied for it, we did an assessment to assess that they're actually in need of PrEP services. We prescribed it, we had it prescribed to them. So there was very little resistance from the providers that we were working with. We made sure that, again, they were culturally competent and proficient to work with the populations that we work with. So yeah, so it's been really, really important to do that.
Let's take 2 more questions for Miguel so that we can.
You want to pick them, Natalie? Because
Yeah. So do you find that clients are going to clinics in South LA? So aside for maybe other services, are they going to South LA clinics?
Not that I know of. Again, we did realize that even our in-person HIV testing, the majority of our clients were coming from SPA 6. We're located in SPA 4 in downtown, Southeast LA, Southeast downtown area. So a lot of our clients were still coming in to get services, but we realized that a lot of them were coming from South LA. So we're happy that they're still coming to the space, because the space is still important. It's been historically been here for over 20 years. So we're really excited that people are still utilizing the space.
Last question, are you getting clients from, were all 600 clients from the LA area?
Those were, we have more that are out of, I should say LA counties and surrounding counties, so 606. So Santa Barbara, Ventura, San Bernardino, Riverside, and Orange County.
All right. Thank you, Miguel. And can you provide your email? Because there's a couple of questions where people want to reach out to you to see if they can adopt your model or if they can work with you. Thank you, Miguel.
Not a problem. Thank you all very much for having me. I really appreciate it.
And if you still have time, feel free to continue to respond to questions in the chat. All right. So next, let's open it up to the panel. Were there any questions? I did see a question regarding why there was such a increase in the transgender community for PrEP uptake. And I think Nina responded. I'm not sure if anyone's here from LA County who can answer that question. No. Okay. All right. Let's see. Any other questions? It's open up to all of the panelists. Please either type your question or unmute yourself and ask the question. So we could probably take about 2 to 3 more questions. Okay, Lorenzo Hinosa, would you mind, let me see. We got a lot of praise for presentation, so I'm looking through the chat to find your question. I believe it was addressed to Lorenzo Banda, right? Let me see. All right, Lorenzo, do you see the question for you? Okay, here we go. What about the term Latinx? It seems that it's a younger generation term. However, what about reaching immigrant populations? Are you making any adjustments there? That's a really good question.
So thank you for bringing that up, because that was something that we've come across. It seems to be a very current term, Latinx. And without wanting to offend anyone, it's a very whitewashed version of Latino or Latina, which is still another category of many different races, right? Colombian, Brazilian, Guatemalan, Mexican, Salvadorian. I mean, there's just so many under the sun. And we have had feedback to where it depends on who you're engaging, and know your clientele. You know, this is true across the board for any business model, is know your clientele and who you're seeking to reach. So Latinx, when it's appropriate, and the new kind of the more telenovela style version of it, and then Latino with respect, or Latina to those linguistics, and when approaching a different community where that's culture is much more respected. Not to say the other is not, but I guess I hope that makes sense. But there is feedback in the differences of approaching someone with those labels. And it all stems from a place of where are you coming from? Are you hoping to identify and then help, or just identify for the purpose of, you know, identifying and really chastising?
All right. Thank you, Lorenzo. There's a question about addressing resistance among providers. And I know that's going to be a question in our breakout session, but if somebody wants to tackle that, how are you handling resistance from providers?
I'm not sure the context. You mean providers not wanting to prescribe PrEP? Is that the?
Yes, correct. So providers who may not want to prescribe within your healthcare system, how are you addressing that?
Okay, we don't have that problem. So
that's why you're a model of best practices. Felipe, you want to talk about that?
I mean, look, I mean, I don't think that's the, I mean, I might be wrong here, but I don't think that's the main problem. It's also just broader conversations about STI, HIV prevention, sexual health. I can get some anecdotal experiences from pediatric clinics in South LA that I visited. And I spoke to nursing staff, and this is about maybe 7 throughout sort of SPA 6. And that's just kind of what they thought their percentage of, say, LGBTQ youth were. And they suspected about 10%. Now, what is that based on? Stereotypes. There's no questioning at all about who these young people are having sex with. So that's one. But then even based on that assumption, how many of them are doing appropriate STI and HIV testing? Urine-based, that's it, right? So then, of course, are they prescribing PrEP? Well, no, right? But it's not necessarily because providers are like, I don't want to prescribe PrEP. It's driven by this lack of whatever in terms of even asking basic questions on people's sexual health. So I think it's so many different things. But I think it's mainly, from my experience, mainly that, you know, I've seen it internally to my own clinic in terms of the various departments that we have. It's not knowing about PrEP and refusing to prescribe it. It's just a general lack of real sort of understanding of the risks and having those kind of tougher, you know, awkward conversations about sexual health. It's my 2 cents.
All right, thank you. Just the last question. And again, if you have any questions, you can continue to type, and our presenters will add their contact information. But we have one last question about what anybody had any success in reaching the youth with PrEP knowledge and uptake.
Lorenzo? I was going to say, I haven't tried to do.
Go ahead and repeat it. I can't see the question. I'm in the chat, but I wasn't able to see it, and I didn't hear all of the question. Go ahead. If you can repeat it, Natalie.
Sure. The question was any successes on how, or recommendations on how to reach youth with PrEP knowledge and uptake?
So the recommendation would be for continued presence, right? And so A lot of times you use Facebook Live or Instagram Live or something like that to reach our audience as an organization. But continue that, even if you don't think people are watching, people do. People respect that consistency. If you build it, it is true, they will come. If you continue to show it, it is true, they will watch. So be in it for the long haul. It's longevity, it's continuity, and we enjoy seeing that. This brings up also kind of our terms lost to care. We continue having conversations. Just because we don't get them into that visit doesn't mean we don't know what's going on in their lives and are invested in their well-being and successes. So don't discount or just kind of write someone off so quickly because you haven't seen them in 3 to 6 months, or you didn't get them in 2 visits in a year. A lot of this is continuous conversations with what's going on in their lives. Hey, I just got a car, I just started a job. All right, can you come in? But it's don't discount youth. Don't write them off. They are a very busy community, and there's a lot of things that they're having to juggle. So give them time and patience. Just yeah.
Thank you. Thank you so much to our panelists. If you have questions, again, the after party is still happening in the chat room. But right now we're going to take a quick 5-minute break and we'll be back in 5 minutes. We have the second panel discussion and we also have a breakout room. So please come back in 5 minutes.
He's coming back from the breakout rooms. I hope you had a great discussion. Usually breakout rooms never have enough time. So I really hope that you got some kind of discussion and we're able to share some ideas around how we can address systemic racism in healthcare. I do know that we are supposed to have a panel after this. And so once everybody gets back, and Natalie's back as well, because I know she's moderating the session. So once everybody's back, we'll get into the next part of the program and we'll be ending very soon. Thank you for your patience. Thank you for joining us this long in this conference. I see Damone, who will be also in the next session on here already. I'll wait for Natalie to come back. All right, Natalie, you can take it away.
All right, thank you so much. Thank you. I know we had a little bit of a drop off when we said we had to roll up our sleeves and make this interactive. We lost a couple of people, but that's okay. I appreciate those that have joined us and those that have stayed. So I see some people, okay, there we go. Not everybody was gone. Some people are still coming back from the breakout sessions. So great job to Damone. I'm here. You did a fantastic job in your breakout session. And now I'm going to invite Damone back to facilitate the next part. And we'll be getting into the panel discussion with individuals who are on PrEP.
Awesome. Thank you, Natalie, for that. And thank you for that feedback. Is Shandy here? I don't see her. don't see her. Okay. So I guess it's going to be a conversation with me and, oh, Shandy, hello. Thank you. All right, so let's get this going because we're on short for time, and I'm very respectful of people's time, and I don't want anyone else to leave us on here. And so we are dealing with a very, as I usually say, it's very sad that in this day and age that we have to be talking about this in 2021. And so, but the issue's there, and so we have to address the elephant in the room. And so just to go right ahead to the question, hey Shandy, and so as Shandy, I just want to ask you, what are some experiences you have had accessing PrEP from provider? You're on mute.
Okay. I haven't had any problems, Simone, because I'm a part of a study for PrEP.
Okay.
So they give me the medication with no problem.
And since you work, because I know you work with other trans individuals, so what have you heard in terms of challenges some of your clients that they may have encountered in accessing the services?
A lot of their issues are around insurance. And how they access PrEP that way. They're supposed to be able to get it, so they've been told, with no problem, but they run into a lot of obstacles through that process of trying to, get past that initial insurance stage and who's going to pay for what.
Okay, so I'm hearing the more concern is insurance, who pay for what, how do I get access to it? And so have any of them been based upon their, their identities that they go by, as that play a factor in impacting them accessing suitable services as well?
Sure it does. Sure it does play a role in it. Trans people are still having issues getting services. As far as we've come, we still haven't got there, basically. I still run into issues with myself navigating services and with my name and my voice and my just everything. It's always, people are always looking for anything to be a reason for them to
be mean,
mishandle you in situations. And the thing about it is that we have to say something about it. If we don't address it in the moment or feel strong enough to address it, then it's going to continue to happen. And so, I'm going to take care of it. You're not going to mistreat me. So, yeah.
Awesome. No, thank you. Thank you for sharing that. And so, Felipe, just to bring you in on the questioning as well. So thank you for your presentation that you did earlier to talk about, racism that exists, within the Black community and the Latino community that people face. And just based upon your presentation and working in the healthcare field, what have you noticed that you have to do differently to kind of help your clients to build that trust?
I don't know if you mean differently than maybe other providers might. I try to be the same kind of provider to all my patients, but I think being, somebody mentioned trauma-informed care. I think it was Terry Smith. I think that's important. I think, one of our persons in our breakout room talked about wanting to have confidence in the provider to be able to actually be honest and share the number of sexual partners that they may have. And I think that's to be able to kind of get that information from a patient, you just have to have a non-judgmental sort of approach. I've always sort of approached it like just about every risk that a person may have. I have or had, you know? And so I think that's the honest truth. And I think any provider who's out there who denies that is just, you know, delusional, to be frank. And so the more we're honest with ourselves, the more we can be honest with patients and talk to them in a way that builds a kind of trust that can hopefully bring out some of that, to say, you know what, maybe in your case, you might benefit from this, you know, from this medication. You know, talking about alternatives, our navigator has been really good about this. Lorenzo was on the call about talking about alternatives to just daily PrEP, you know, thinking about 2-on-1 dosing, you know, in terms of, you know, just having confidence that our patients, you know, in spite of appearances, have agency and might say, you know what, I think I would benefit from taking this 2-on-1 dosing, you know, and not having to take a pill every day, et cetera. So, so I don't know. I mean, you know, I think that's I mean, there's nothing radical about it, but it's unfortunate that there's this kind of divide between patient and provider that needs to be, that barrier needs to be removed, you know.
Yeah, and no, thank you for sharing that. And you raised another concern regarding the 2-on-1, but just before I get there, and the reason why I asked you the question differently, because like if there's anything differently, because sometimes you may have individuals be like, oh, I haven't been to the doctor because, you know, of this issue, you know, how I was being treated, how I was not being respected, you know, as an individual.
Mhm.
Person, you know, as a client, as
Oh, yeah.
here, you know, because, you know, when trans person step in, is like, okay, it's like they immediately, you know, just assume everything and don't ask those questions, and then when they're corrected, they don't take that correction. And so that's what's the nature of my question. And so, and throwing it back out there, you know, back at Shandi, regarding, have you heard of I know you work in the field, so you probably heard of it, but has your clients heard of, you know, the 2-1-1, and has that something been their interest, like, okay, this may be something I can do if I don't want to take that daily pill? Has that been an option that has been that they have asked about?
No, they haven't asked about 2-1-1. Or I should say the ones that I've dealt with have not asked about 2-1-1.
Why do you think that is?
Because they have so many other things to focus in on. I mean, trying to live their lives. Because a lot of the youth that we deal with are homeless. So their focus is on a whole nother level of trying to prioritize things that will get them through the day.
Right. So other
thinking
social
about tomorrow is at another moment. They're just trying to get through the day. So yeah, no, they haven't asked about 2-1-1.
Yeah, so other social determinants of health is more prior to this 2-1-1. So, and that's definitely, you know, always the case there. And so sometimes when they get frustrated with the system, they're like, okay, I can't bother with the system. Let me just do what I need to do. And so I just want to piggy on a question from the chat. So Ace is asking a question. Ace, do you want to unmute and ask a question so that you can ask it more clearer than how I would read it?
Sure. So I know you're saying that there are some folks who are having a hard time paying for PrEP, and they're worried about paying for it. Have you, when it comes to using the PrEP app program or Ready Set PrEP from the federal side, so the PrEP app from the California side for individuals who are making, I think it's 500% of the poverty level, so $60,000 a year, it's supposed to be covered for free, including labs. So I was seeing is there any challenges to actually utilizing that we need to speak to the Office of AIDS about, to say like, hey, there's people who are trying to get PrEP for free, who need PrEP for free, and they can't do it. And then for the people who are non-residents, say like you're visiting from New York, Ready Set PrEP is supposed to be available for you or something too. For individuals who are making less than, you know, 60,000 a year. Is that have you seen that barriers to accessing, utilizing those systems?
I mean, if I could chime in. So first off, no, just as a quick answer, I know we use PrEP AP. We use actually Gilead iAssist as well for that sort of first year. And our navigator and some of our other folks who are actually more doing the benefits to figure out, you know, which sort of, you know, line item or whatever is paying for the PrEP. But no, I think that's the quick. I think the problem that we've had though is when they have other medical issues. So for example, a mono-infected Hep C patient who wants to be on PrEP, for example, and then thinking about that, or just having other medical issues and they have, say, a restricted Medi-Cal because they're undocumented. And so, but they're seeing me who want to get some of these issues, but I'm only technically seeing them for that one PrEP issue, but they have primary care issues. I think it's that sort of like gray area where I'm finding the most difficulty. I feel like we're able to work around those things, but in terms of getting PrEP, I think we've been okay. For those who are getting here to us in our doors, getting the folks who need to be in our doors, that's the bigger question.
Well, I've never heard of Ready, Set, PrEP. So thank you for opening my eyes to something new, because I had never heard of it. So
because that's one of the big pushes we've had with the CDC is to make sure people are aware of it. So the state of California does PrEP app, so like the assistance program. So it's very similar to like some things that happen in other states to make sure that if you are a resident of California and you earn less than $61,700 a year, you'll have access to the medication and the labs. And then Ready, Set, PrEP is the federal government's version of it. That only kicks in if you're not using the California one. And that's really for people who either make more than $60,000 or for people who are visiting California, like someone who's like, just from a different country, but they can't say that they live down the street, regardless of whether or not they're a citizen or non-citizen.
Great.
Thank you for sharing that, Ace. Thank you. Thank you to my presenters. I have room for one more question. So if you have that question, you can type it, or if you want to unmute and ask, you can go ahead, because I want to hand over back to the team. But before, I just want to thank you both. I want to thank the individual that actually did the video presentation, and that video presentation will be available on the CHIPS website that you can see it. And so please check that out. And thank you, Ace, for sharing that information that's useful, and that's, as somebody who work in the field as well, that's useful information for me as well. So that's something that I can also share with individual that we can have access to. Thank you, Shandy. Thank you, Felipe, for your tremendous work and that you're doing and continue to do it. Thank you. And I just hand over right to Natalie.
Yes, thank you, Damone, for facilitating the panel discussion. Elena has typed in the chat information about Ready, Set, PrEP, if you need more information about that. We don't have time for the report back. We did have note takers. So for the note takers, if you can please enter it into the Google Doc. We will be putting a document together regarding these breakout sessions, any best practices and the conversations and input that we've had. And as a reminder, in order to get CEUs, to complete to make sure that you're registered for CEUs with Pacific AIDS Education Training Center, and an evaluation will be sent out via email. And as a reminder, please complete the evaluation. It's really important for us to get feedback. We know that we're not going to tackle and address all of the systemic racism in one day or in one conference. This was really just the start of the conversation to say that in communities of color, that we need to tackle systemic racism in our HIV efforts to increase PrEP uptake, but also in our efforts to end the HIV epidemic. I'm now going to hand it over to Brandon, who's a co-chair of CHIPS, to close this out.
Thank you, Natalie. Thank you all so much for attending today. Thank you to our presenters and our moderators and our panelists. We really do appreciate you all for joining. And remember, if you need CEs, Dami has chatted in a link to get there. And on behalf of the CHIPTS CAB, we thank you so much for coming today.
Great job, everybody. Thank you.